Hello Deborah, I am Dr. Tiwari.
Okay.
I am welcoming you. You have a lot of things to know about
Yeah.
general anesthetics, its implications and complications, and what are the outcomes can be, and is there any other modalities other than general anesthetics that can be used for your patient.
Okay.
You are most welcome. You have any question, any query, you can ask me, I will answer you.
Thank you so much. What is general anesthesia?
See, there are different types of anesthesia techniques. General anesthesia means putting the patient to sleep, unconscious and unresponsive.
Okay.
Okay. There are other anesthesia techniques. One of the modality of variant of general anesthetic is total intravenous anesthesia. Total intravenous anesthesia is we don't use gases.
Okay.
We use drugs. It's a continuous infusion process and patients goes into similar plane of anesthesia.
Okay.
And other techniques are regional anesthesia. Regional anesthesia can be a field block, can be an neuraxial blocks, can be local infiltrations, can be nerve blocks.
Okay. You've talked about general anesthesia. Is it one way of making someone become unconscious?
Yes.
When that person is undergoing something called surgery?
Yes. See, general anesthesia is preferred whenever we are operating on a person above abdominal wall, above umbilicus. Because when you operate someone above umbilicus, the regional techniques of block given may be insufficient. And when the surgeon feels that I am not getting adequate relaxation,
Yes.
and patient's anxiety is further complicating the procedure,
Yes.
so he may ask go for a general anesthesia. Yes, and there are few surgeries like neuroanesthesia, like cardiothoracic anesthesia, like laparoscopic surgeries. The preferred technique is always general anesthesia.
Okay. So what's the main reason as to why someone can get general anesthesia? Not to feel pain or to be conscious?
See, there are different components of general anesthesia. If you go to the Goodell's time of anesthesia, when ether was used as a sole agent, and when it was able to produce a general anesthesia for the plane of surgery, we call it surgical plane of anesthesia,
Okay.
the dose would have been very high, and patient can have toxicity when we attain that.
Okay.
And chloroform was one of the volatiles notorious for this because it has a very narrow window
Yeah.
of therapeutic window we call,
Okay.
where if you increase there is a toxic effects on heart, if you decrease there is no anesthesia.
Okay.
Okay, so when anesthesia evolved further, because if you look at the history, there were deaths every 1500 patients one used to die
Okay.
because of some anesthetic complications.
Okay.
Then today if we say it may be 15 lakhs of persons operated, then one patient may succumb because of some mistakes. So it has been great advantage, and whatever stages of anesthesia that we used to achieve, like you have to make patient unconscious, you have to make patient paralyzed, you have to control his respiration, you have to control his heart rate. These stages were giving toxicities also.
Okay.
So this current technique of general anesthesia, we call it balanced anesthesia,
Okay.
where we use different agents to achieve these different goals.
Okay.
Like muscle relaxations, we achieve with muscle relaxants, pain relief and sedations with opioids, inductions with propofol or thiopentone, they are IV induction agents. Then we have nitrous oxide or helium as a co-port for the volatile gases.
Okay.
And these volatiles also nowadays, they have a very excellent, we call it partition coefficient and recovery rates. The moment you decrease or you cut off the volatiles, patient comes out of it within no time.
Okay.
And same thing with the muscle relaxants. Now we have different kinds of muscle relaxants. They are cardiac stable, they are having, free from nephrotoxicity.
Yeah.
There are muscle relaxants that can be used in a patients of kidney failure. because they are metabolized with different techniques that is called Hoffman elimination. So these muscle relaxants are very short acting.
Okay.
Or even their action is intermediate duration. We don't have a long acting with cumulative toxicity drugs nowadays.
Okay.
So patient recovers fast, and we use every components of anesthesia, dosage of different drugs in combinations to produce surgical plane of anesthesia without giving any toxicity to the patient.
Okay. For example, if a patient dies during surgery, is it because maybe the surgery came to a point that the patient had to die, or is it because of anesthesia?
See, nowadays we have better equipments.
Okay.
We have better monitoring standards. We always monitor. Throughout the patient is monitored on table.
Okay.
So if some patient is dying, it has few lacunae somewhere in the system. That lacunae can be when the patient was not undergone pre-anesthetic assessment.
Okay.
Whatever the complications patient has, whatever the comorbidity patient has, it should be extracted out of the patient. Then anesthesiologist is prepared to handle such calamities. If I know you are suffering from heart disease, if I know you are taking some anticoagulants, I know your sugar is uncontrolled, I know your kidney is not working well, I know your liver is failed, you are having cirrhosis. So we can take optimal measures so that patient is not exposed to the toxicity of the drugs.
Okay.
And further, the patient's parameters, the volatiles given, they are monitored throughout. What is the inspiratory tidal volume, what is the expiratory tidal volume, what is the inspiratory concentration of the drug, what is the expiratory concentration of the drugs, airway pressure, there's so many things monitored. Continuous ECG monitored. Further, the patient's invasive blood pressure is monitored, patient's central venous pressure is monitored, everything is monitored nowadays. Then further, we call something photospectrometry, where the patient's awareness level also is monitored. How much is the depth of anesthesia is monitored. So nowadays, if something happens, it is most of the time because of some surgical complications arising during the procedure.
Okay.
And when the anesthesiologist is not able to cope with that complications that have arisen. And the most common complication is bleeding because of some reason.
Okay. And does a patient get more than one anesthesia?
Yeah. See, when we are planning you for a particular, say, technique of anesthesia, we have accepted you in the American Society of Anesthesiology grade 1 or 2, whatever is grade, we have accepted you. There what happens, when I am taking you for a spinal anesthesia, suppose,
Okay.
and my spinal anesthesia has not been able to produce enough anesthesia,
Okay.
and patient is crying, patient is telling he
patient
is
is
feeling
still-
pain,
Yeah.
then there are different techniques to supplement this pain.
Okay.
We call it supplementation. Even for the spinal anesthesia, we sedate also, that is called pseudo-anesthesia. When the patient is having pain, suppose when the patient is light during some plane of anesthesia, there also we can supplement in emergency with certain drugs.
Okay.
We can increase the volatiles, or we can just add on some our inducing agents like propofol, just give a little, maybe 1 or 2 ml, patient will certainly become deep. Then meanwhile in 2 minutes time, you attain the level of anesthesia. But there are different techniques. And post-operative, suppose a patient is operated for transhiatal esophagectomy. It's a huge surgery where esophagus is resected. In this surgery, patients have severe pain post-operative. And pain is from thoracic cavity to the abdominal cavity. How we can achieve? We have to supplement. So in these patients where you feel that no, let the patient not have any pain, we supplement analgesia. Like we give epidural analgesia.
Okay. Is there any complication that a patient gets when undergoing anesthesia or after?
Yes, patient can undergo certain complications. These complications are because of certain pre-existing conditions. At times when anesthetist is not able to judge the level of anesthesia and patient does some painful procedure and patient is in a lighter plane, patient can go into bronchospasm.
Okay.
So when the patient is in bronchospasm, There is no medicine to break the bronchospasm. Only the patient can break himself when he becomes very flaccid.
How long does a patient wakes up from consciousness when he has undergone after surgery?
Yeah, see, nowadays, I told you, we have very better techniques of monitoring. We have better techniques of vaporizers, where even the circle system of the anesthesia machine, where a very low amount of volatile is circulated every time into the system. So when you cut off, like old days, if you go for halothane, isoflurane, they used to take a lot of time in coming out of it. It may be 10 minutes, it may be 15 minutes coming out of the anesthesia.
Okay.
But nowadays, with the newer volatile agents like sevoflurane or desflurane, patients comes out very fast. When you cut off, within 2 to 3 minutes time, patient will energize, provided you have optimally used the muscle relaxer.
Are there some of the things that a patient should avoid before undergoing surgery?
Yes, it's
Like?
very important. The most important thing is the patient should be fasting when he's coming for anesthesia.
For how
People
long?
may question, when I am going for a regional technique, what is the purpose of fasting? You are not going to give me general anesthesia, but you told that patient may need certain supplementations or maybe certain techniques if he's feeling pain. So when we have to talk during the procedure and patient is full stomach, there is no time to say him you go and fast and come, because we are halfway the procedure.
Yeah.
So patient is always advised to fast. Fast means clear fluid, water 4 hours. If you have milk and some juice, 6 hours. If you are having some non-veg preparations, you should fast for at least 6 to 8 hours.
Okay. And what is the most common drug used in general anesthesia?
I told you, we use balanced anesthesia. Balanced anesthesia means we have inducing agents. Nowadays, whatever we are using here is common, and most of the developed countries they are also use propofol for induction.
Okay.
Next drug comes for the intubation. Intubation, we generally avoid succinylcholine. We are going for either atracurium or vecuronium or rocuronium for induction. We are using induction agents like propofol, which is commonly used across the globe. Then for muscle relaxation and intubation, we are using atracurium, rocuronium, vecuronium, mivacurium. These are the drugs commonly used.
Okay.
Then patient is given something called preemptive anesthesia, where the opioids, the newer generations of opioids are given, like fentanyl, sufentanil, alfentanil, these are given. Once the patient is induced, intubated, then the patient is given nitrous oxygen mixture or helium oxygen mixture with volatiles.
So what's that one last thing that you can tell our viewers about general anesthesia?
General anesthesia today is one of the safest technique. And you should, if you have any doubt, you should talk to your anesthesiologist. If you are taking any medicines, if you have any history of allergy, if you have any comorbidities like blood pressure, diabetes, you have some cardiac illness, you have some kidney illness or liver illness, you must tell your doctor. Or if you have any past experience which was very adverse in your anesthesia, you must explain it to your doctor.
Thank you so much guys for clicking into this video, and we'll talk more about anesthesia next time when we meet. Subscribe, watch and share to your friends. Bye.
Thank you very much.